Good morning, everybody, or good afternoon, depending what part of Canada you're joining us from. We'd like to welcome all of you and thank you very much for joining this special session that we have offered for all of our nurses to celebrate Nursing Week. So today's presentation is going to be given by four of us, and our topic today is Building Bridges, looking at the heart-brain connection from a nursing perspective. We're very excited today that this presentation is part of Heart and Stroke's outreach. We're at the point of trying to build relationships with many other organizations, and we know that nursing is a huge, very important part of care for anybody with heart disease, stroke, vascular cognitive impairment. So we're thrilled that we've been able to bring all of these groups together. And so the National Emergency Nurses Association is joining us, the Canadian Association of Neuroscience Nurses, and the Canadian Council of Cardiovascular Nurses. We also welcome some of our other friends from the Nurse Practitioners Association and the Holistic Nursing Associations. They've both reached out to us and wanting to work with us, so we're very excited to have all of those groups join. So today we're going to give you, in February of this year, we released a very important report where we've combined all of our knowledge into one report called Disconnected, really looking at the heart-brain connection and what that means. So today's talk is taking that one closer and really looking at it from the nursing perspective and through the eyes of nursing. So I'll give you an initial overview and talk a little bit about the nursing role. Cindy will then follow up with going into some of our data and really showing you what impact you have and what the patients you deal with are actually, what that looks like over time. And then Joe, who's one of the National Emergency Nurses Association members, is going to bring this back to the real life. What does it look like on the ground when that patient's in front of you? And then Andrea will summarize with some call to action and moderate our question session. So none of us have conflicts of interest that are relevant to this presentation. Because it is Nursing Week and I am a nurse by training, I always start these kind of presentations with reminding of our roots with Florence Nightingale. Her birthday is on the 12th, so it's coming soon. And I think some of her quotes that you'll see throughout are very poignant to this presentation. You know, nursing puts the patient in the best condition so that they can heal. And we play such an integral role in that we always want to be reminded of that. So happy Nurses Week to everybody. You know, we do recognize the important role at Heart and Stroke. We have many volunteers that are nurses, and we're grateful to all of you. And when we hear stories from patients with heart conditions, with stroke, with vascular cognitive impairment, when we ask them what made a difference in their care, the nurses that cared for them are, you know, almost always one of the first things they say. So your impact is felt, it's appreciated, not just by us, but also by those you serve. And I want you to always remember that. So just to give you a bit of an intro to the report, I'm sure many of you have looked at it already. We put this out in February, and it's our first ever combined report. And the goal of this, and what we want you to take away from today, is that conditions of the heart, the brain, whether it be stroke or cognitive impairment, aren't separate. And our health systems, as you know, are kind of built in separate silos for these conditions. And our goal is to help break that down. And you as nurses have challenges by trying to maneuver through those different silos, but you care for the whole patient. So for you in your practice, it isn't siloed, but you have to deal with the silos in the system. It's important that we start with remembering that this isn't just about an acute event or one point in time. The messages we're sharing today and our care for our patients really covers the entire continuum of care. So really think about what part of the continuum you practice in, but remember that you also have to think about what's happened to that patient before they show up on your doorstep and where they go and what happens to them afterwards. We'll start by introducing a concept of the heart, brain, and mind. Now, mind has many meanings. In the context of this conversation and the work we're doing, it's really about the cognitive piece. And so we know that through heart conditions and stroke, people are much more susceptible and at risk for cognitive impairment. And that's the part of the mind we're focusing on. So traditionally, you know, the thinking, the memory, the language, being able to process executive function. And that conditions that involve cognitive impairment really range from mild cognitive symptoms to very severe dementia. One of the things that we did is really try to understand what is the relationship between these conditions so that we can start to break down silos and build better systems that are more efficient in handling patients with multiple issues. So we looked at each of the conditions, and if you look across each row, you'll see that if you have that condition like atrial fibrillation or heart failure, and you work across a row, you'll see that if you have heart failure, there's a strong association with atrial fibrillation, with stroke, with cognitive impairment. If you look across, you see where those associations are. If you look down, you'll see that something like cognitive impairment has a dot for every condition. That means for any of those conditions on the side that are listed, they all put you at increased risk of cognitive impairment issues. And basically, all of these conditions, we say all roads can lead to dementia. As you can see by some of these numbers, that people have a much higher risk of cognitive impairment with any of our major heart conditions. What we want you to do today, and as you move forward in your practice, is how do you integrate supporting the care of the whole patient with, potential relationships between heart and brain. So let's take a minute. I'll give you a second to read through this. And really the message here is it's time to start thinking outside the traditional healthcare boxes or silos and really broaden your perspective. Now, nursing already does that, so really looking to you to champion this message to your other colleagues in whatever setting you're practicing in. What we've heard from our patients and the reality that they deal with is they often have multiple conditions, which Cindy will show you about in a minute. The challenges they face are navigating the different aspects of the system. They really don't understand what cognitive impairment means or really the extent of what heart disease means, so there's a health literacy issue. They feel disconnected and siloed, that they don't know how to access specialists or there's big long waiting lists, and that when they leave the confines of the inpatient setting and those walls, many of them get lost in the system and just don't know what to do or how to move. And the result of that is frustration, lack of control, being unable to cope. So what we've been doing is calling for action among many groups to help make this better. From a nursing perspective, we practice within patient-centered care. That's always been our guiding principle, and really looking at it through Picker's 8 principles, as you can see on the screen, and really, wanting to promote advocacy, empowerment, autonomy, and making sure patients have a voice and are active participants in their care. The theme appropriately for Nurses Week this week, which worked out perfectly, is a voice to lead. And it's a voice to lead with other healthcare providers. It's your voice to lead and speak for your patients and teach them how to speak for themselves and to really improve care. So we just wanted to take that theme with us through the rest of this talk. Nurses' voice helps to support patients throughout all aspects of the event, in assessment and monitoring, dealing with the family on an emotional level, education, and helping them through transition. When we look at all the different places and ways people can transition, you see that it's complex. And as Florence said, were there none who were discontented, we'd never reach anything better. So there's a lot of discontentment about navigating through the silos, and we want to be making it better. So when you think about assessment from a nursing perspective, that there's the heart, the brain, and the mind, or the cognitive impairment piece. As you can see in the highlighted in blue, many of the aspects of your assessment are the same. So when you're doing the history, think about all 3 of these at the same time. It's not 3 separate histories. When you're checking risk factors or blood pressure, it's for all 3 of these. And then within each, there's a little bit of specificity around, heart in terms of its function, such as cardiac output. For stroke, it's around the signs of stroke or deficits, which is your Rankin score, your functional impairment measurement scale. So there's different scales to measure, but the idea of measurement and the psychosocial has to be part of all your assessments. When people move out of the confines and the safety of the inpatient setting, that's when things really become challenging. And in the community, nursing plays a critical role in family practice, in community nursing, in working at clinics to really provide education to help patients integrate. And we have created a checklist for transitions that's in our Canadian stroke best practices, but it applies to stroke, heart, and vascular cognitive impairment. And we encourage you to look and follow that and to use that as one of your tools. When you're in the primary care setting, which is where most of the care for these patients happens, their time in inpatient is so small and limited, most of their care happens in the community. And really think about those different roles, which is you're guiding patients, you're making calls, you're directing them, you're helping them to adapt to their needs, you're thinking about aging patients and the frail, but also now younger patients who are starting to have these diseases. And the big role is prevention. When you think about what do you want for your patient at the end of all this, is we want them to have the best outcomes possible. And so there's nursing outcomes, which we'll talk about in a minute, but then there's also the outcomes through the eyes of the patient. So a patient outcome is a measurable individual, family, or community statistic looking at the behavior perception from their eyes. And the ICHOM group actually have developed outcomes for many of our diseases. And here's some examples from the ICHOM inventory. So when you look at it from the nurse's perspective, because nurses more and more have to be accountable for their practice. You know, in the past, we actually created evidence-based care in tracking through Florence. But now it's, again, that we have to be more accountable, justify what we are, who we are, what we do. And so we really need to look at thinking about outcomes and how we measure not just the patient's outcomes, but our own and the impact of our intervention. So when we look at this all together, there's the nursing theory, research, education, and practice. And that's important to look at our traditional components, but we also have to then apply our experience and critical thinking and our interactions with everybody else, including our patients, the families, and the other parts of the system, and do it in a compassionate way. And that's what makes us unique. And so really with thinking about patients from a heart, brain, and mind perspective, you really have to apply all of these at the same time. So I'm now going to turn it over to my colleague Cindy, who's going to talk to you more about the data. I want to remind people, as I do to Cindy often, is it all started with a nurse. That, you know, Florence, during the Crimea War, started to collect data which helped improve care. And she said, but when I use data, because people didn't listen to her otherwise, about the outcomes of the bad sanitary and medical conditions, you know, where there were so many unnecessary deaths, people can argue when you put concrete data in front of them. And so Cindy has been a valuable part of our team. She's building this incredible data access portal for us, and she's going to talk to you now. Thank you.
Thank you very much, Patrice. And before I dive into the data, I also want to take this opportunity to thank all the nurses. My father has an open heart surgery, and the first thing after the surgery is that he thought the nurses was angels. So thank you very much for taking care of everyone else, including my family. And switching into a little bit gear, and this is, as Patty have mentioned, you know, data is one of the most needed information for us to really have a clear sight of what we're doing every day, why we're doing every day is important, and what is the outcome of it. And, you know, another very famous quote here is one needs to get together data that is as complete as possible so that we can actually see what we are trying to do at the end of the day. And from an organization like us and yours, I mean, data is very important for us to speak to the urgency and the burden of the disease that we work hard to care for. How many people are affected? How often does it occur? Why do I care? Why do we work so hard for it? And why do we need to act now? And the most importantly, what happens if we don't do anything now? It really speaks to the actions and why we're in this field working so hard every single day and night. So tying this to some of the data we have shared in our 2019 Heart and Stroke report, one of the key messages that have come up from the data is that there's a very complex connections among all these diseases that we are caring for and working hard for. In Canada, one person died every 5 minutes from heart condition, stroke, and vascular cognitive impairment. Some of you may have realized that this differs from the 1 in 7 minutes we have spoke to previously because we have now expanded our data to also include vascular cognitive impairment, which you have seen and have heard and will hear more about its critical connection to all the heart disease and stroke. And more importantly, many patients and families are not aware of all this interconnectedness, and this actually really changes how patients and families care for their own conditions, as well as it has impact on healthcare providers and system leaders on how to better educate our patients and families, as well as how do we care for them. This is data from our Data Hub, which is an interactive online data and knowledge sharing platform that you can follow up and dive more into on our public website after this webinar. And I'm just highlighting some of the key data that is relevant to your day-to-day work. We trained the data from a hospital administrative database and have identified that in the past 10 years, since 2007, there has been an increasing burden in this conditions. And this put a very immense strength on a healthcare provider, including nurses like you. In particularly, the greatest increase we saw in hospitalization were for structural heart disease, a 50% increase, and vascular cognitive impairment related conditions had a 35% increase, and we continue to see a 25% increase in heart failure related hospitalization. This is a very scary graph to look at. As you can see, a lot of all these conditions have an upward trend. Looking at our hospitalization data by age and sex, we also see that out of the 2.6 million hospitalization over the decade, there are more female at the age 80 or older visit the hospital because of either a heart condition, stroke, or vascular cognitive impairment. As you all know, that women often outlive men, and this really speaks to the disproportionately impact on women's life and how we care for them. Another striking finding was that we also saw an early onset of this condition in the patient pool, which really complicated how we care for them and how these people actually have to care for themselves for more years of their lives. So one example here you're looking at is that for heart failure, we actually see a 52% increase since 2007 at the age group of 30 to 39 for reasons for being hospitalized. And speaking back to the point of this condition are connected, when these people have the condition earlier, this also increases their risk of developing other conditions subsequent to in the rest of their life, which then really further challenge our already overloaded health system because of multiple conditions. And it also really affected how people have to go back and forth to the hospital and get readmitted. And we also see that, at least 40% of people were discharged, and then following on, they go back to the hospital for a second event. So this really have an impact on the nurses' workload, the healthcare provider workload, and also have a lot of impact on the primary care teams, as Patrice has talked to you earlier on. And speaking about return visit to the hospital, of the 40% of people who have to go back to the hospital for additional cares after either heart disease or stroke or vascular cognitive impairment, you can see that about 88,000 people return for at least a stroke or vascular cognitive impairment. And for those who have a heart condition, about 530,000 people actually return for another condition subsequently. This really complicated how we care for them and how we speak to them and communicate and work with them. And lastly, going back to one of the key findings from this report and from our the data that is shown in this Data Hub, this data sharing platform on the website, one of the most shocking and critical connections that we have identified is this strong association with vascular cognitive impairment. So showing here on the screen, you can see that a large proportion of stroke a large proportion of vascular cognitive impairment patients also have stroke, atrial fibrillation, and heart failure, as well as the ongoing research and new findings that is tying vascular cognitive impairment with other heart conditions and stroke. And lastly, really want to speak to this piece is that in addition to the growing trend, there is also a trend that we have observed is unique patterns for women. The risk for women is actually much higher for men. Looking at this graph over the 10 years we have looked at, or 16 years in fact, the trend is actually growing, and you can see that women are getting affected even more. And this really resonates very well with our 2018 Misunderstood report, as well as 2018 Life Destruct report, where we have also saw that women are affected disproportionately in comparison to men. And lastly, as we talk about women, one other thing that we have really worked very hard on, and some of you may have been participants of Facebook Live Women's Awareness Campaign last spring in 2018, and also may have heard of our hashtag Time to See Red, is that we really see that there is a huge gap in research, and there's a lot of work we need to do. And one key point that we would like to highlight is that 2/3 of the heart disease and stroke clinical research focuses on men, and Heart and Stroke is doing a lot of work to try to move the needle on that, so that we can better understand what matters to women, how we can improve our care, and how we can better treat a woman who is affected by heart disease, stroke, and vascular cognitive impairment. All right, with that, I'm going to be very happy to introduce our next speaker, who is from New Brunswick, Joe, and he is a critical care nurse, and he will be sharing with you his experience as a nurse. Over to you, Joe.
Okay, so thank you very much. I do want to talk just a little bit about some things that I've seen in my work as a critical care flight nurse, as an ER nurse, as an educator, just to provide a little kind of on-the-ground clinical perspective. I do want to say that the information presented in this presentation is my own opinions and opinions from conversations with colleagues and patients. So we're going to talk a little bit about what I think that we do well in emergency departments and in emergency and transport care. Talk a little bit about some of the challenges, some that were mentioned in the report, and some other things that I've noticed just through my work and through conversations, and identify some potential areas for growth. There we go. All right, sorry about that. So I think we do triage fairly well in emergency departments across this country. We use the Canadian Triage and Acuity Scale, which is a comprehensive triage tool developed in concert between the Canadian Association of Emergency Physicians, the National Association of Emergency Nurses, and the Canadian Pediatric Society, among other contributors. So this just all meshes together really well to create a comprehensive tool that we can use to triage these patients effectively and ensure that they do get the care that they need in the most appropriate time. Things like CVA. We can manage strokes very well. We have established clinical protocols throughout this country based on evidence-based data that's been gleaned through years of study, and it helps us to glean assessment data, things like the chief complaint, symptoms, pain, vitals, assessment findings, and it also establishes baseline protocols for these patients. So, the time that they present to the emergency department to the time that they receive treatment to the time that they refer to definitive care. We have some benchmarks that we can look to provide best care for these patients. STEMI is something we also do fairly well across the country. We have guidelines and algorithms for the treatment of ST elevation MIs. These processes are reviewed as new data comes in from evidence-based research and consensus statements, and there is buy-in across the board when it comes to things like STEMI care. Buy-in from multiple stakeholders that help us to provide the best and most effective care for these patients. And I've just thrown a couple examples of clinical guidelines and STEMI protocols just from a couple places across this country. Resuscitation is something that we also do fairly well. We have, again, established protocols for resuscitation of these patients. Most ER staff are educated in a variety of aspects of resuscitation and take multiple courses regarding the same. There are uniform approaches to resuscitation that are based on best practice, and most facilities have adopted these guidelines. But there are some challenges that we face as well. As was mentioned in the report, there can be a siloed approach. Many aspects of medicine are complex, and in order to have the ability to provide the best care possible, the practice is to establish specialists in certain areas. And as we refer to these specialists, we get feedback and guidelines based on these specific care presentations, but not necessarily to deal with the patient as a whole. So that can present a challenge. Patients are presenting more and more with multi-morbid complications. These age-related factors can often play into the way that we are able to treat these patients, geriatrics especially. Women, again, as was mentioned earlier, women can present with a variety of conditions that have physical symptoms that are not necessarily typical of the condition when you would see it in men. And in that same way, geriatrics can present with atypical symptoms for a variety of conditions. Access to care is also a particular challenge to people, especially in rural areas. There's a variety of reasons for this: socioeconomic status, geographic location, or a combination of the two can affect patient access to care. Due to a lack of available primary care, patients may present in their local ER for issues that a primary care provider would normally look after. And this can cause challenges with respect to continuity of care and with appropriate follow-up. Patients who are in geographically isolated areas often may be transported to tertiary referral centers for care. And this can lead to patients receiving care in multiple, not even only multiple facilities, but actually multiple provinces receiving care at the same time. So it can be challenging in these cases to maintain continuity of care. Crowding has also presented a challenge. Due to hospital overcrowding, the ER has become a very busy and often chaotic environment. And this can make things like healthcare teaching and advocacy a challenge to accomplish in a busy emergency department where the care load is just so high. So we also do have some areas for growth. There's technology-assisted healthcare. The electronic health record provides care data from multiple sites. In New Brunswick, we have a pan-provincial system. So if a patient presents to a healthcare facility, any diagnostics that they undergo, any consultation reports, discharge summaries, lab work, and also the drug information system, which is used by all pharmacies across the province, is now housed in one electronic health record that all care providers in the province can have access to. And so this helps to reduce things like polypharmacy, to reduce the instances where maybe care information has not been passed on to a primary care provider for things that were done in hospital or in clinic. But again, as I mentioned, with geographic isolation, I think there is a potential for a national database as well, whereby these patients who are receiving care in multiple provinces, the care providers would have access to all of their healthcare data in one spot to allow for greater continuity of care. Wearable technology is an emerging field that has potential to provide real-time data to help us care for these patients. And when used in concert with things like consultation via distance, these technologies can allow for greater access to specialist services and more effective and appropriate care. In New Brunswick, we do have some rurally located level 3 and level 5 hospitals where they don't have access to things like neurological services. So when a patient does present with a CVA, as an example, there is consultation by distance that happens with an on-call neurologist who's able to review CT reports and actually video conference at the bedside with the patient, do an assessment, and recommend potential treatment options for that patient. Staff education is also an area for growth. We as nurses, we do try and we should continue to look for opportunities to be continually better educated. There are various critical and emergency care education programs across this country which do address the complexity and interconnectivity of patients' acute and chronic conditions. So these programs should really be fostered in the emergency department and other care areas, and new staff should be encouraged to complete these programs. And in addition to that, experienced staff should be encouraged to maintain certification in these courses to ensure that best practice and uniformity of care is accomplished. As patients live longer, they often do accumulate multiple comorbid conditions. Geriatrics, much in the same way as pediatrics, is a special population subset, and education, I think, is needed to more effectively assess and manage these patients. I think staff could benefit from the development of educational programs specifically tailored to the growing geriatric population. While the community resources do continue to develop in areas, awareness of these resources may not always reach the acute care frontline provider. Development of and maintenance of a list of available community resources could be beneficial because if we're aware of these resources, even in a busy place like an emergency department or critical care area, we can more effectively advocate for the care of our patients. And lastly, interdisciplinary connectivity. As comorbid presentations become more common, so too should the development and implementation of multi-system care plans. These plans, when used in association with things like interdisciplinary rounds, have been shown to have a positive effect on the holistic care of patients. And units that deal with these patient populations should be encouraged to develop and implement these processes. Interdisciplinary rounds can include all areas of care: RN, LPN, RT, physical therapy, occupational therapy, discharge planning, pharmacy, dietitian, responsible physicians. And it doesn't have to be a long and complicated process. In our emergency department, we're just implementing interdisciplinary rounds for admitted patients. It's going to happen on Monday, Wednesday, Friday, and we're just going to spend a minute per patient. So just a quick summary of the plan of the, we call it plan of the day and plan of the stay. So where is this patient today? What things do they have going on? What consultations, what testing, what results, and what is the plan for their stay? What are the processes being implemented to help get this patient closer to discharge? And what can we do as individual care providers to help further those processes to get this patient home or to an appropriate care center? These processes can help all care providers to maintain a better and more holistic situational awareness of each patient, and it can be a great tool to help us move past the siloed approach that has become prevalent in much of healthcare. So that's it for me. For the next portion, we're going to turn it over to Andrea.
Thank you very much, Joe. We greatly appreciate your frontline perspective on the challenges and opportunities that were faced with the current healthcare system when dealing with a siloed approach. So to summarize, we're going to end with a call to action. So we're going to look at what can health systems, services, and providers do. So with that, we want to always keep in mind that holistic model of care. Sometimes we can be really focused on that medical model, which looks at the disease and illness, and we want to transition to a holistic model where we can, that focuses on the whole person. So it incorporates, looking at the social determinants of health, considering education, housing, food security, equity, and trying to keep all those in mind as we care for our patients. We want to have a streamlined and supported patient care and patient and caregiver navigation. We want to have improved communications with patients, families, and caregivers. We want to educate patients and families and other healthcare providers. Use common assessment tools and common languages. With that, as Joe was discussing, patients and families are often transferred through multiple care areas, potentially different cities and different provinces. If we're able to use common assessment tools and common languages, it'll help keep that care seamless across the different care settings that people are transitioning through. It also helps when patients are transitioning through different parts of their journey, from acute care into rehabilitation to community settings. If we're all speaking the same way, it'll make that experience better for them and help to avoid any information being lost along the way. Electronic medical systems to facilitate communication between providers. This was also, Joe also brought this up. It's with the increasing acuity, increasing volumes that we're experiencing in our healthcare system, an electronic medical system will help us to make sure we keep our data on track and help keep all the information accessible by all the people within the circle of care. Increased services and support for northern rural communities. Again, Canada, we have this unique geography where we have some people, who live in very far areas, and we need to make sure that they also have equal access to healthcare services, and that can be through telemedicine services and other different modalities there, and making sure that they are able to get the same services as those in the city areas. And we want to commit to equitable care for women, Indigenous peoples, and complex patients. So prevention is critical. So we want to raise awareness among the public, healthcare providers, and system planners and funders. So governments play a key role in this to enable healthy environments and choices in population health prevention and policies and strategies. So for example, this goes, to the marketing that's on cigarette packages, all these ways that we can help to promote the public to make healthier choices. Researchers need to identify better ways to make prevention successful. We need to look at our upstream thinking with that. We need to focus on avoiding the condition from ever happening, as well as that care after someone experiences an event. Healthcare teams must also become better at presenting the needs and options for healthy choices to patients and families. And employers can play a role as well. So for example, Heart and Stroke is conducting an employer-funded pilot study to provide health coaching to consumers. And individuals have to act. So the last bit here is this change approach to systems of care. The health system needs to move towards a patient and family-centered model that efficiently meets the needs of people with multiple conditions and diagnoses all the way through recovery. And it's not just to recovery, but all the way through to the other side and resuming that new life. So we need to look at how people are able to reintegrate into their lifestyle. It looks at their work life, their education, their family activities, and we need to consider that in that holistic approach to care. And Dr. David Hogan, he is a physician out in Calgary. He's a geriatric physician, and he defines his practice as, he doesn't define it by the age, he defines the practice by the age of the patients, not by whether they have a particular disease. This again looks at more of that holistic perspective of that individual, as every individual patient has their own unique needs that they require. So it's important to consider the whole person, their values and beliefs, because they play a significant role in planning and decision-making about their health care. We need to treat the person rather than just treating the disease that they're experiencing. So we're going to invite everyone to ask questions. And you can add them into the question box. We do have a couple questions here that we'll read out. So the first question is, how much education do you offer to a TIA or heart failure patient who is being referred to a tertiary hospital?
I'll start and I'll let Cindy also respond from the heart failure side. Education is a unique thing. There's no set amount. The important thing is that you assess what the patient's personal needs are, what their gaps in knowledge are, and really try to fill in those gaps for them. Often patients in an acute setting will need to hear the information more than once and in smaller, simpler chunks until they're ready to really process a lot at once. So really think about the timing. But, always start with doing some sort of even a quick needs assessment. What is it that you need to know most? Or, they won't know what they don't know in some cases, but really the bottom line is as much education as they need to be able to function and manage their disease. And for some people that's less, and for others it's more. So it's really an individualized approach with the patient in front of you.
Yeah, and this is a very timely question because we just have a heart failure awareness webinar yesterday, and actually this week is also heart failure awareness week as well. So I would say in terms of education, as Patty had mentioned, it needs to be repetitive, reiterative. Ask your patients and their family how much they understand. Ask for acknowledgement so that you can understand where they don't really quite fully grasp the idea or where they may have confusion. And then reinforcement is probably the most critical part. And there are many different resources out there that present the same material in different ways, but that's another good approach to get the message to different patients that may be more receptive to maybe resources that are in different type of language or different format or different visuals. So try that as well and reach out to your facilities, organizations, and also local authorities and see what various resources they have.
Thank you. So another question here. When services are not easily available in our community and patients cannot afford to travel, what do we do?
So that's a big challenge across all of our disease conditions where smaller communities don't have, resources for patients or even services such as rehabilitation or prevention services. In that case, it's really, we've been really promoting telemedicine and the use of digital technologies to help get patients access to the care they need. There's a whole bunch of telerehabilitation programs that have started and speech language programs that are digital now, available through apps, either on an iPad. And if patients don't have those or can't afford them, hopefully the health centers, and we have lots of examples in the north, where health centers have those iPads and will lend them to patients to help them get some of the services they need. It is a big challenge. It means, and what I've seen in some of my travels to those areas, is the staff in those areas become the jack of all trades. They become the nurse, the physio, the OT, the speech language, all at the same time. And that's a real challenge when you've got multiple patients to care for. There are a lot more resources that you can find on the heartandstroke.ca website that will help link you to other activities. And most of the provincial websites will have local resources or ones that are close by. And you can reach out to the next closest community that has services and see if they can help you and share and find creative solutions. Cindy, any other comments?
No, I think you covered it very well on that one.
Joe, maybe if you're online, I'd like to hear your thoughts on that from some of the work you've seen in your travels.
Yeah, I can certainly echo those sentiments about the lack of in-person services available in geographically isolated areas. And also for patients who maybe just don't have the socioeconomic means to allow them to travel to areas to receive those referral services. So we do have some things in place, as were mentioned, some portable technology implementation. There are actually some devices that can be used to, a patient can hook themselves up to a blood pressure monitor, to an SpO2 monitor, even to a 3-lead cardiogram, and that data is actually gleaned into the machine and transported to a care provider where they can then take that information, and it's a little more data to be able to help us to provide follow-up and referral services for these patients. That being said, I think it's certainly still an area for growth, and there's a lot more work that we can do in those areas.
Thank you.
Thank you very much, Joe. So another question here, from a chronic disease management perspective, our clinicians want to spend time focusing on holistic care. What suggestions do you have for incorporating that into their 50-minute appointments with internist patients, etc., when they have wait lists that are several months long and patients' chronic conditions are numerous and complex?
So this is a very big challenge where, especially when you're seeing specialists, they're going to focus on their part of your condition, and they really don't build in time to look at all the other pieces. But that's the part of the system we're trying to change, is really, especially for people who live further away. We've heard stories where somebody comes in, they have to travel like 1,000 kilometers to get care for one of their conditions, and then they're sent back to their home community to wait to come and have to travel again to see another specialist. So really working within the system to try to group appointments so people can come down and see multiple people, but also, more integrated clinics where those services are available all together. Part of the work that we're going to be doing is really also training or educating those specialists on the need to have a broader perspective and to help them better understand some of the challenges patients face with, only having pieces of their care looked at in one session. One of the things that's probably our biggest risk in this area that we're really promoting is the issue around medication, that if you're really only focused on one condition, oftentimes patients, especially elderly, will run into trouble with multiple medications that may interfere with each other or cause significant adverse reactions when put together. So there's a lot of issues, and we're trying to educate through all of our outreach to professionals. I think we have a ways to go, but we are starting. Cindy, any other?
I think adding to that is also, to the point is patient cannot ask questions of what they don't know. So another part of what we do a lot here, and then I'm sure Joe at your end as well, is to educate the patients and provide tools and resources to them to empower them so that they can learn to be a stronger self-advocate and be able to figure out how to best communicate and work with healthcare providers like you and nurses when we all know that every single appointment has very limited time.
Okay, thank you.
Okay. So next question here, are there any education modules available that can be added to our specific e-learning software? Most sites who have developed training want to maintain ownership of their software, incurring increased costs and inconvenient record keeping for small hospitals with limited resources.
So I'll talk a little bit about now. It's not clear whether this is e-learning for patients or for healthcare providers like yourselves. So from a healthcare provider, within Heart and Stroke, if you go to the Stroke Best Practices, there's a whole series of webinars like this one on different topics that can be accessed for free. They're open access that people can access to learn about some issues. We recently did one on return to work, which is a major issue for people with heart disease and stroke. So there are professional resources out there and information. From a patient perspective, we do have some programs, but we're currently actually in the process of building a whole new patient platform to offer more digital e-learning for our patients. Cindy, do you want to comment more about that?
Yeah, so I think what we are looking for is, how do you personalize the patient experience and also the family and caregiver experience using our webpage, and be able to reach out to those who are not close to your urban center. I can see in the Q&A there's also a question about support for those who are in the rural community, which really ties to how do we get the words out there so that we can reach out to more people. So really just trying to use digital technology to really trying to figure out what are people looking for and how do we make the navigation a little bit easier for them, because I think a lot of the time is patients want to look for things they need, and yet there are so much out there on the internet, it makes navigation very difficult.
Thank you. So on that note, we're going to end this webinar. Thank you everyone for attending, and happy Nurses Week to all the nurses out there. Thank you so much for all you do. We're so lucky to have such great nurses in our country here. So if you have additional questions, you can email them to the Stroke Best Practices email that's in the webinar link. And thank you very much.
We look forward to having more interactions with all of our nursing groups in the future. So please let us know any other topics that you'd like us to address and that we can work together on, because we're happy to support some of your programming through this webinar opportunity, and to have more people involved in all of our development work. We'll be reaching out, and we look forward to working with you in the future. Thank you again.
Thank you so much, everyone.
Bye.